We shall now go on to our last speaker, Dr. SHORYA VARDHAN, who is the consultant Vitreous Retina Services from RP Center. Is he there with us?
Yes, ma'am.
Yeah, so look forward to your talk.
Yes.
Okay, are my slides visible?
Yes, yes, yeah, yeah.
Yes, sure.
Okay, fine. So at the outset, I'd like to thank Chitra ma'am and AIOS for giving me the opportunity. And as everyone else has also talked about terminologies, I'll be talking about a little bit more. So I'll be talking about CRORA and IRORA and focal choroidal excavation. So OCT has gone through the revolutions, and definitely since we can see many more structures than we could before, we are now having a lot of terminologies, and it's at times difficult to keep up. So the first two terminologies are basically related to AMD. So they are related to both dry and wet. I'll be discussing how they are related. So first, the dry AMD has always been, sort of the definition goes by geographic atrophy. So it was around an oval area of hyperpigmentation or depigmentation, visible underlying choroidal vessels, and they gave a definitive size to it, and it was classified on a color fundus photo. Recently, they have been monitored with the help of FAST, and some of the studies have actually used geographic atrophy even for wet AMD. So it's a loose term. So what now has become is that we have got a classification of atrophy. So there were people who have all the panel of retina specialists and other retinologists, histologists came together, and then they gave a consensus terminology defining atrophy specifically in AMD. So before, it was being seen on a color fundus photo and a FAF. Now it is being seen on an OCT, because the OCT can give a layered evolution of these changes of retina, and which was not possible otherwise. So there are series of 6 meetings that have been done till date, and the first meeting was done to discuss all the modalities that we have at present, which can assess the atrophy, and they all the panelists, all the experts, they debated about the advantages and disadvantages, and they came to a conclusion that for non-neovascular AMD or dry AMD, a colored fundus photo, FAF, infrared image, and an OCT should be done at the baseline and the final outcome point. Whereas for a neovascular AMD, because of the neovascular membrane, FA is also recommended in addition to these at the baseline and at selected follow-ups. With report 3, they came up with 4 terms, out of which we'll be discussing 2. One was complete RP in outer retinal atrophy and incomplete RP in outer retinal atrophy. So let's see how they fit into the AMD spectrum. So the atrophy in AMD is actually divided into dry or wet. It can be in either. So typically it was described in dry AMD and what we knew as geographic atrophy. So what we have as complete RP in outer retinal atrophy is a broader term for geographic atrophy. It can be present in wet form as well as in dry form, but geographic atrophy has been retained specifically for dry AMD. And nascent geographic atrophy is the term which will be given to incomplete RPE in outer retinal atrophy. So what exactly is complete RPE in outer retinal atrophy? Well, previous studies have actually mentioned all of these. They have just given a particular dimension to all of them, and they have called it a particular sign. So it's a region of hypertransmission of at least 250 millimeters in diameter, as you can see by the images, and a corresponding zone of attenuation or disruption of RP, and an overlying photoreceptor degradation, and it should be in absence of a RP or a RP, scrolled RP, or a sign of RP tear. So what are signs of photoreceptor degeneration? Well, it has been discussed earlier that there is thinning of the outer nuclear layer, loss of IZ, EZ, and ELM. So it's already been discussed. Then moving on to what is incomplete RP in outer retinal atrophy. So anything which did not fall in the category of CRORA came into IRORA. So if there is increased signal transmission and a corresponding attenuation of RP with overlying photoreceptor degeneration, but not conforming to the size, then it would be termed as IRORA. And they would be thought as a precursor preceding CRORA. So if you can see over here that you can see large drusen's and pigmentary changes in a clinical photo. And if you see on the OCT, you are seeing the subsidence or sinking of the inner nuclear layer and the outer plexiform layer. And there's loss of EZ, IZ, and the ELM, and there is increased signal transmission with RP attenuation. Another case, there was same finding, except that you can see a wedge-shaped defect, hyporeflective wedge-shaped defect, which is there in the Henle's layer. It's another sign of IRORA. So this is a case of IRORA going into a CRORA. So if you can see at baseline, there's a large drusen and few pigmentary changes, and then you can see on the corresponding OCT that there was a drusen, and the drusen has still has a hypertransmission, and there's ELM disruption as well. But the RP is fine, so it does not fall in the category of IRORA. And at 6 months, this changes and the drusen collapses, and then you have increased transmission, you have signs of out of photoreceptor damage as well as attenuation, and then it becomes an IRORA. At 18 months, the IRORA has established itself, but then it is still not meeting the criteria of a CRORA. So at 30 months, you can see that there is complete loss of the RPE, and then it starts falling into the category of CRORA, and then it becomes established more so at 48 months. So what are the implications of these findings? Well, as it has been proposed earlier, the nascent geographic atrophy goes into geographic atrophy. It's similar over here as well, that IRORA then progresses on to CRORA. So basically now we have some sort of a parameter that we can check on an OCT, and then we can plan interventions so that we can stop it at the stage of IRORA, and probably even try to find a time point at which we can reverse the changes and not go into irreversible changes. So basically, it is just a way of finding a reproducible measure which can be used in trials so that we can have interventions which can reverse the process if possible. Moving on to the second terminology is focal choroidal excavation. Well, it was described first by Jampol et al. In 2006, and it is nothing but a concavity in choroid, which is mostly macular and rarely extramacular. It presents mostly in the 4th and 5th decades. Is reported mostly in Asians and associated with refractive error like
So 1 minute remaining.
So FCE can be classified as conforming type, in which the retinal layers actually conform to the cavity, and non-conforming types where it does not conform to the cavity and there's a hyporeflective space between the RPE and the photoreceptors, or as congenital or primary, which are present since birth probably, and are just incidental findings on an examination, and acquired or secondary types in which their primary pathology is something else, which actually leads to a focal choroidal excavation. So I'll just be discussing few cases. So this is one patient who came just for a eye checkup, for a refractive checkup, and we found a pigmented lesion just above the disc, and on OCT you can see that there is a cavity and there is the retinal layers are conforming to the cavity. So it is probably a conforming focal choroidal excavation, which is congenital because he did not have any other associated pathology. So going on to acquired pathologies, so this is a case that we published, choroidal osteoma, and we can see that as the evolution of osteoma goes on, there is deossification of the osteoma that might lead to cavities that are made in the choroid, and this is a form of an acquired sort of a non-conforming choroidal focal choroidal excavation. Then it can also be associated with inflammatory conditions like punctate inner choroidopathy. So you can see that these punctate lesions that are there at the macula, and on OCT, if you can see, there is a small excavation, and it also happened to house a CNV, which is a known association. It can also be associated with dystrophies. So in such a case, this case was of a Stargardt disease, and you can see that there is a excavation in the choroid, and the layers of the retina conform to it. So it is a conforming focal choroidal excavation, which is seen in a Stargardt disease, probably due to degeneration. So implications, well, if it is a congenital, mostly seen in myopes, not associated with any chorioretinal disease, it's supposed to be stationary, and it's an incidental finding and should not be vision threatening. In acquired cases associated with chorioretinal diseases, it may progress to complications and lead to vision loss like CNV. And also cases of pachychoroid CSC have shown to be associated with focal choroidal excavation, and thus if stationary lesions, I would not mind following it up and probably just seeing an OCT through that lesion, maybe every time the patient visits, to see whether there is any progression in such cases. Thank you.
Thank you very much, Doctor. So much of information, and each talk one to beat the other. Srinivas, do you have any question to ask?
No, I think he has covered it really well and deciphered it very nicely, line by line. I think it was very clear. Nothing more to add. I think we can have, the time is up, and we can have some final comments from two of our panelists, Dr. Anand sir and Dr. Uni sir, please.
Yeah, I mean, specific to this talk, I mean, excellent, very elaborate talk. Focal choroidal excavation, we've seen in a host of pathology, touched upon a good number. It's part of the pachychoroid spectrum and acceptable aspect. I think the one thing that we need to just understand is that when you see that cavity there, a lot of you should not jump the gun and think it's fluid that needs to be treated with repetitive anti-VEGF therapy. So it's part of the pachychoroid spectrum. That's the only aside. But otherwise, I think you covered those things well.
Yes.
Last comments from Uni sir, please.
And basically, it was a great talk. I just want to just make a small stress. This is just a small thing for the general ophthalmologist. The term that is introduced, CRORA, is the umbrella term. Geographic atrophy is a subset of CRORA. You can define CRORA in the presence of elevations of the RP, that is PED and CNV. So geographic atrophy is when basically when the RP is flat. So it's a subset of CRORA. Anyway, it was the whole seminar was a very great teaching experience, and it was a pleasure to attend and hear everybody, including Anand with his insightful comments. Srinivas, you did a great job moderating. Dr. Giridhar, Dr. Muralidhar, all stalwarts and seniors. Great to see Dr. Sharon also.
That's absolutely wonderful session. I mean, the energy levels are amazing. Dr. Chitra leading from the front. Srinivas always was an energy pack. Thank you very much. Great thanks to all the speakers. I think everybody did an excellent job. There's a huge amount to be learned and a lot of insightful interactions and comments from Uni and everybody else here on the panel. Thank you very much.
I think I'll give my conclusion remarks, and I would just like to reiterate what Dr. Uni and Dr. Anand said, that there has been truly great contributions from the expert panel and extremely capable speakers who left no stone unturned. And I think it's just one more milestone that ARC has seen today, to leave behind a much remembered webinar. Our special thanks to one and all of you. My thanks to my co-moderator, the young hero, Dr. Srinivas, and my strong ARC team. Thanks to AIOS admin, Mr. Kripal, with his team who are always there for us. Sai and Manjula from Numerotech for our great strength. And of course, Anand Sethi, whom all of you would have interacted with, the meticulous way in which he forwards the link and keeps tab on how the timing of the webinar goes on. Our most special thanks to Entoad. They have been our major sponsors and have been constantly there supporting and backing any number of webinars which I try to conduct. And finally, I think it has to be said again and again that if we keep trying to do better, it's the amount of interest which are shown by attendees and the number of them watching. And believe me, I keep getting to hear and see that how these YouTubes and websites are visited over months. So believe me, dear speakers and expert panel, that all these talks will be heard by many, many more over the months to come. And I think we leave behind a truly great library of knowledge. Thank you very much.